Nat asked me to talk about blood salvage and surgery in obstetrics, which is a topic that's near and dear to my heart. I just wanted to start off with a little historical perspective on this particular topic, which was the origin of autotransfusion or cell salvage, blood salvage, whatever you want to call it. Autotransfusion is probably a more precise term. But this concept of collecting the patient's own blood and re-administering it dates back to this case report from 1874, where William Highmore postulated that it would be quite valuable to be able to collect blood in a patient's bed, filter it with gauze, and then just re-inject it. And this was first postulated in the observation of a young woman who was hemorrhaging to death following childbirth. So this was the primary way of transfusing patients for about 50 years until the development of the washing machines that we currently use. But in this 50-year period of time, there's about 3,000 case reports of unwashed, salvaged blood being collected and re-administered. And in general, as is seen from this case series, the patients did pretty well, except when the blood that they were collecting was old. And this particular case series reported on 3 deaths that occurred when blood of greater than 3 days old was being reinfused. And even to this day, there are a couple of organizations that have developed devices to do this unwashed blood salvage, and primarily focused on the third world. CISU Global has got this syringe type device that they're currently trialing in Ghana. And it basically sucks blood from the surgical field and then through a closed system is able to re-inject it into the patient. And then there's also this HemoClear device that could be used in a third world setting, which is basically a fancy filter. It was developed in the Netherlands. So following on this origin of autotransfusion, this particular device, the Bentley Autotransfusion system, was developed in the 1970s to basically collect blood from the surgical field and through the use of a roller pump, basically pump it right back into the patient. The problem with this particular device is that the roller pump didn't stop when this particular device, this globular reservoir, when it emptied, the roller pump wouldn't stop and it would continue pumping. So there was a number of deaths that resulted from air emboli from this device. So it didn't stay on the market for very long. Subsequently, there was the development of these washing machines where the blood was collected, concentrated through centrifugation, and then washed with saline. And this is kind of the new fancy high-tech device that we use in our operating rooms. This machine is manufactured by Sorin. There's also machines manufactured by Fresenius and Medtronic and Haemonetics. So when these devices were first introduced to the market, there was a couple of contraindications that were felt to be absolute, and it was primarily derived from the fact that these manufacturers couldn't do clinical trials to really prove safety. So instead of proving safety, they just simply labeled the devices as being contraindicated in these particular surgical settings where there might be tumor in the surgical field or where there might be amniotic fluid contamination. So I wanted to address these two particular areas of contraindication because I think they're rich opportunities to salvage the patient's own blood and give it back. So I'll start with blood salvage and obstetrics. This is the area that I spend most of my time clinically practicing in. But the fear with using autotransfusion in obstetrics is that the amniotic fluid might be entrained into the blood and lead to what we have historically called an amniotic fluid embolism, which actually might not be an embolic phenomena at all. But at any rate, amniotic fluid embolism is this spectrum of problems with cardiopulmonary arrest being the end result. And it's really bad when it happens. And I'm sure many in the audience have experienced this, and it's devastating to all parties. The problem with this particular phenomena is that it's very rare. The incidence has been reported to range from 1 to 8,000 to 1 to 30,000, with an average being about 1 per 19,000 deliveries. So you have to have a very busy unit to actually see one of these on any regular type of basis. And when it does happen, mortality rate is somewhere between 60 and 80%. And of those that survive, 25% of them are neurologically intact, with 75% of them not. So it's a bad thing when it happens. So we don't want to iatrogenically be causing this by entraining amniotic fluid into our salvaged blood product. The problem, and this is what the manufacturers faced when they first rolled out these devices, is that again, the average incidence of this particular problem is about 1 per 19,000 deliveries. So if you were to do a study to prove safety, this is a power analysis that I did a number of years ago, but you'd need 1.7 million subjects in a study to prove the safety of this technology. And fundamentally, I've never seen a study with 1.7 million subjects. Even all of the studies with tranexamic acid were huge, but they didn't even approach this particular number. So fundamentally, we're never going to be able to conduct a study that is going to prove absolute safety of cell salvage or autotransfusion in obstetrics. So when I started using it, I asked myself these three questions. Can the biochemical contaminants be adequately removed? Can the cellular contaminants be adequately removed? And can I remove the bacterial contaminants to a degree of safety? So we'll start off with biochemical contaminants. This was a study that was published back in the late 90s that looked at tissue factor removal. And tissue factor is thought to be the entity that causes DIC, or the coagulopathy that follows the resuscitation of somebody suffering from an amniotic fluid embolus. And you can see on the far right-hand column that after a washing cycle with the standard cell salvage system, tissue factor is pretty much completely removed, at least in this small study. And in general, if you look at any kind of biochemical contaminant, they tend to wash out in parallel with each other. And this particular study looked at potassium as a marker of washing quality, as well as the removal of platelets. And you can see that both products were removed in parallel in an exponential fashion. So if you ever have any concerns about impurities being in the blood, just increase your wash volume. So now what about particulate contaminants? This is something called a leukocyte depletion filter. This particular filter is manufactured and sold by Haemonetics. It was designed specifically to be used in cell salvage. so that the flow rates of this particular leukocyte depletion filter are much greater when compared to a standard blood bank leukocyte depletion filter. So to show you the effectiveness, I have some pictures of blood that's been contaminated with amniotic fluid. And this particular slide shows you blood that had all the amniotic fluid from a particular cesarean section that was entrained into the cell salvage reservoir. And so what you see here is these red things. These are fetal squamous cells. And then you have this stuff, which my pathologist who I worked with on this study called amorphous gunk. Then these black dots are leukocytes. And then in the distant background are the red cells. This particular staining technique didn't highlight them, but you'll be able to see them here in the subsequent slides because the power magnification is increased. So this is what the blood looks like after washing. And again, you still have these fetal squamous cells, you still have the leukocytes, and you can better see the red cells now because this is a higher power magnification of this particular blood product. And this is what the blood product looked like after passing the blood through one of these leukocyte depletion filters. And you can see here now that all you have is red cells suspended in normal saline. So the combination of the processing, the washing, and the filtration leads you with a product that's basically 100% red cells. So when I did this study, we looked at a maternal blood sample that was drawn from the vena cava right outside the uterine veins. And we drew this blood sample at the point of placental separation, which we postulated would be the time that the vast majority of the amniotic fluid contaminants would be entrained into the systemic circulation. And we compared that maternal sample to a post-wash, post-filtered blood product. And we found that, in essence, the post-wash, post-filtered sample was cleaner than what was actually circulating in the mom. So it seems to suggest that we can return a blood product that's safe for the mother. Now, what about bacterial contaminants? This is something that is of concern when you've had somebody that's been in labor for 2 days. Their membranes have been ruptured. They've developed choreo. So can we remove these bacterial contaminants? This is another study that I conducted where I took blood from the blood bank and I contaminated it with a number of different bugs shown here on the left side of the slide: E. coli, Staph aureus, Pseudomonas, Bacteroides. And these were inoculations that the microbiologists that I was working with on this particular study said were massive. And then we basically washed it and filtered it, and were able to achieve almost 100% removal of each of these bacteria when we did this combination of washing and filtration. So I think we can produce a relatively safe blood product from bacterial perspective also. Now, one of the things that the reviewers of this particular study required me to do is to do a dose response curve. So I inoculated a number of different units with Bacteroides specifically because it was the bug that was least removable. And we inoculated doses from 10 to the third, as is shown in this left-hand column, all the way down to 10 to the 7th. And what we were able to demonstrate is that consistently, and by the way, this is just filtering the blood product. There's no washing that took place with these particular units of blood. But we were able to achieve these kinds of mean reductions just with filtration. But the point being here is that when you start off with a high level of contamination, you can remove 80% of it, but you're still left with a fairly high number of bacteria that is in the blood product. So the take-home point being is that if you have frank stool in the blood, it's probably not wise to process that particular product. This 10 to the 7th is about what you would find with frank stool being in the blood product. So just to give some perspective on what these numbers mean, this is a summary of platelet contamination cases from the blood bank at Case Western Reserve in Cleveland, where Rosalind Yomtovian looked at the contamination of platelets and found that there was fairly high contamination rates in the platelets that they were transfusing in their patients. This is a problem that has disappeared because we're doing bacterial testing now. But at least back in 1993, this was the leading cause of death following the administration of a blood product. So I think our 99% removal of bacteria is adequate in combination with antibiotics during the course of cesarean section. So now in the literature, there's about 1,665 cases of cell salvage being used or autotransfusion being used in obstetrics with no adverse outcomes being reported in those cases. And for that reason, all of these organizations in Great Britain and the United States recommend autotransfusion be considered anytime there's massive bleeding during a cesarean section or delivery. Now, we utilize it, not in every case. We use this standard when we've gone through 20 packs of, or rather 20 swabs or laparotomy pads, when they've been utilized and we're opening up another pack. That's the time that we basically start bringing in the autotransfusion device. And a must do when you're doing this particular processing or procedure during the course of the cesarean section is that you need to wash or rinse these swabs or laparotomy sponges, as is being demonstrated here. A typical swab will contain about 100 mLs of blood. You can remove 95% of it by simply rinsing it into the cell salvage, or rather into a bowl of saline, as is being shown here. And you can end up with a swab that looks like this. It's basically free of most of the red cells. And then you simply suction this saline red cell mix into your cell salvage device and process it as normal. Most of the blood lost during a cesarean section is going to be on these swabs or laparotomy sponges. So it really is mandatory that you do this when applying this technology in this environment. So I wanted to move on to talk about cancer operations and the use of autotransfusion. And this is an opportunity that I think is missed greatly in the United States. There is a universal fear of oncologic surgeons of using autotransfusion in cancer care, but I think it's misguided and it can be done safely. The main question is, does cell salvage collect and concentrate tumor cells, which could lead to massive disseminated metastasis? And fundamentally, the short answer is no, but I'll show you some data that supports my perspective. Now, this comes from Ernil Hansen, who practices out of the University of Regensburg in Germany, where he looked at a number of different cancer operations and found that there was widespread, and I'm sorry that it's so small that you can't see it, but he found large numbers of cancer cells being incorporated into a salvaged blood product. And Erniel has advocated the irradiation of a salvage product, which I think is a bit overkill. But one of the interesting findings in his particular study is that he drew blood samples from the patients that he collected blood, and found that in about a quarter of these patients, there was already circulating tumor cells. So it really begs the question of what does it mean to inject a autotransfusion blood product into a patient that already has circulating tumor cells. And the significance really is illustrated here. Circulating cancer cells were first recognized in 1869 in patients that had tumors, which is a long time ago. And multiple investigators have demonstrated that the presence or absence of circulating tumor cells has little prognostic significance. Again, really does that influence whether or not we used autotransfusion during cancer operations? So now this particular study highlights the masses of tumor cells that you might find in patients with malignancy. And what they did is they looked at cancer cells from a number of different types of cancer. You see on the bottom what those cancer are. And then they compared the number of cancer cells to patients that had either a benign tumor or had no tumor. And you can see the number of cancer cells per 7.5 mLs of whole blood could be quite high, especially in breast cancer patients. You can see that in that 7.5 mLs of whole blood, there's one patient that had almost 24,000 cancer cells in that blood sample. And if you translate that into blood volume, it basically multiplies out to be 667 times. So 667 times 24,000 is a lot of circulating cancer cells. So again, it highlights the importance or the lack of importance of collecting cancer cells during the course of autotransfusion and re-administering it. So what happens when you administer cancer cells to a patient? And this particular individual, Chester Southam, was an investigator at Sloan Kettering Cancer Institute, and he took a variety of cancer cells and injected them into prisoners and what were described as senile patients over a 10-year period of time, and found that nobody who had these cancer cells injected into them subsequently developed cancer. Ultimately, Dr. Southam was found guilty of fraud, deceit, and unprofessional conduct. And he is used as an example of unethical research practices because of his injecting these cancer cells. But the take home really is that none of these subjects developed cancer following the injection of these cells. So part of the reason is the inefficiency of metastasis. When you inject cancer cells into immunocompromised mice, the vast majority of whom will die without developing into tumors. Now, I introduced this particular filter a short time ago for the use in obstetrics. And it also has a role in cancer operations. This particular filter will remove anything that has DNA in it, and tumor cells are one of those things that has DNA. So these investigators found that the use of these leukocyte depletion filters would completely remove tumor cells. So I think we can produce a product that is devoid of cancer cells and potentially offers an opportunity for better outcomes for patients. And so with that as the introduction, there are a few outcome studies using autotransfusion in tumor surgery. This is one of them that I published. This was a meta-analysis where I collected about 15 different studies that had been performed in cancer operations and found that, in fact, when autotransfusion, if you look down here, this is a summary of all these studies. When salvage was used, autotransfusion or autologous blood was used in cancer operations. When compared to allogeneic blood, the patients actually had slightly better outcomes long-term than when allogeneic blood was used, as is shown here. Another study, here it is in urologic surgery. These investigators found pretty much the same thing, is that there was a strong leaning towards better outcomes in patients that received their own blood during the course of their surgery. And these are just some of the demographics of another study that was performed. This was done at the University of Pittsburgh, where we looked at urologic cancers, and we compared preoperative autologous donation versus cell salvage. And these are the demographics of the two groups. And this was all done with one surgeon, our chair of urology, who is a big fan of using cell salvage in cancer operations. But what they found was very interesting. Even when comparing autologous blood versus autologous blood, they found that there was a higher rate of biochemical failure, meaning PSA increases in the patients that received stored blood, meaning preoperative autologous donation. Metastases in the PAD group were higher when compared to the cell salvage group. There was no difference in mortality, but you can see in the bottom line of this conclusion that there is a strong signal that mortality may be influenced also. So just to finish off, I just wanted to talk briefly about the biological filters that are available for use with autotransfusion. There are screen filters and depth filters. In the standard collection reservoir, there is a screen filter. And the screen looks like a window screen where there's basically a porous material, and anything that's larger than these holes will be captured in the filter, whereas anything smaller than those holes will pass through. And these are some of the filters that we have available. The filter on the left, far left, is what's called an SQ40. It represents that it's a square, and then it filters out anything that's greater than 40 microns. The filter in the middle is a LipiGuard filter, where the filter material has been coated with something that attracts lipids. And then the leukocyte depletion filter is shown on the far right. And this is the capacity for each of these filters, what they're capable of removing. Again, the SQ40 is a microaggregate filter. It simply removes stuff that's bigger than 40 microns. The LipiGuard works similarly. The depth filter, though, is how the leukocyte depletion filter works. And so it basically contains a layering of filter material, polyester fibers that are layered first at the top of the filter, and this loose weave is shown on the left side of the slide, and it gets even more dense as you move down through the filter material, as is shown on the right. And so these filters don't work in the same way the microaggregate filters do. They don't screen, they adhese particles based on the membrane charge. And just to give you some understanding of that, a red cell is about 5 microns, whereas these bacteria are much smaller, like 50-fold smaller, and they will be removed from these depth filters, whereas the red cells will pass through. And the reason is related to some of these characteristics. Most of the products will adhere to the filter material and be stopped before they exit the filter. Just a couple of caveats about the use of these filters. First of all, the blood bag needs to be pressurized in order to get adequate flow rates through the filter. And the filter will get plugged up after its use, so it needs to be changed about every 500 mLs. So I will just leave you with a picture of Pittsburgh, since I'm talking to an audience that's about 6,000 miles away. This in the foreground here is the University of Pittsburgh, where this particular building, the tall one, is what we call the Cathedral of Learning, where our chancellor resides. And then in the distant background is the city of Pittsburgh. And then the far corner here is a very important structure in Pittsburgh. It's our football stadium. So with that, I will leave you and thank you for listening.